I'm going to be talking on Hodgkin's lymphoma, latest concepts. Those are my disclosures, although they have no relevance to this talk. So the main intent of Hodgkin's disease today is to really create less toxicity, because at least 85% of Hodgkin's patients can anticipate a cure. So the charge for us is to cure even more patients with the least impact on their well-being. With this in mind, I'd like to talk briefly about what role does this PET scan play in this effort. Essentially, can interim PET or CAT scans, or PET CATs, be of value, or should scans be used only at the end of treatment? With this in mind, I'd like to talk to you about a study which I did in conjunction with Dr. Hutchings and Dr. Kostakoglu, which was looking at PET scans after one cycle, which is 2 treatments, or after 2 cycles, which is 4 treatments of therapy. That is, looking at Hodgkin's patients after 1 month of therapy and Hodgkin's patients after 2 months of therapy. And what we're looking for is to see which had a higher predictive value, the PET scans after 1 cycle or the PET scans after 2 cycles. And the participating nations were Denmark, the United States, Italy, and Poland. Now, the patient population was 126 patients, but as you can see, there were stages of all type. We had over half the patients with B symptoms, a third of them had bulky disease, so it covered the entire gamut of stages and risk factors for Hodgkin's disease. And what we found out is that the negative predictive value of a PET scan after 1 cycle was 98%, as compared to the predictive value of PET scans after 2 cycles, which was 91%. On the other hand, the positive predictive value was really superior for the second cycle, which was 85% as compared to 63%. Therefore, the sensitivity for PET-1 was greater, but the specificity for PET-2 was greater. So what we were saying here is if you have a negative PET scan, you could probably stop right then and there. If you had a positive PET scan, you probably should do a second cycle. Now, a lot of controversy has been created over the ability of one PET scanner to read the scans as opposed to a second PET scanner. Let me simply say that we had pros looking at these PET scans, and the concordance was approximately 90%. So with that in mind, I'd like to talk about an abstract at the 2012 ASH, which came from the British group called the Rapid Trial in Patients with Clinical Stage 1A, 2A Hodgkin's Lymphoma and a Negative PET Scan after 3 cycles of ABVD. Not 1, not 2, but they gave these patients 3 cycles of ABVD. And what they essentially did is if they found the PET was positive, they would give the patient a 4th cycle of ABVD and then involved field radiation. But if the PET were negative after 3 cycles, they randomized them between involved field radiation and no further therapy to see if a PET scan could predict well enough that these patients did not need radiation. And what they found was that, in fact, that the PET negative patients had a higher incidence of relapse. And in terms of progression, there was 20 versus 9. But the number of deaths, these deaths encompassed all kinds of complications, were far greater in the involved field radiation, so that the progression-free survival was pretty close at the end of 3 years, and overall survival gave a slight edge to those patients who had negative PET scan. Now, they had determined that 7% difference would be allowable, and in fact, the risk difference was just 3%. So they had 602 patients, 75% were negative after 3 cycles of PET, and in the randomized PET negative population, the progression-free survival was 90% versus 93% for involved field radiation. So what we found out basically was that you really didn't need to irradiate these patients. So in conclusion, patients having a low stage of disease with a negative PET scan after 3 cycles of ABVD have an excellent prognosis without further treatment, and for these patients, radiotherapy can be avoided. There's some commentary. These data are very similar to those reported from Argentina several years ago, not just for limited stage, but for all stages of disease. And I contend that a higher rate of false negative PET scans after cycle 3 seen in those patients might have been avoided had we done the PET scan after 1 cycle or 2 cycles. And of course, response adaptive therapy based on quality controlled, assured PET scan imaging may become the future standard of care in early stage Hodgkin's lymphoma. So the conclusion from this study is that you probably don't need to irradiate those patients with limited stage disease. Now, there was another study reported at ASH on an individual patient data comparison of the German Hodgkin study group HD10 and HD11 combined modality therapy and the Canadian trial group HD6 using ABVD alone. Now, the Germans have really pioneered using limited amounts of chemotherapy followed by radiation, and the Germans, what they did is they divided their early stage Hodgkin's lymphomas into what they considered favorable and unfavorable. Essentially what they're saying is if you had 2B disease or you've had other disease with these risk factors, and I think most of us will accept a large mediastinal mass and 3 or more involved lymph nodes or extranodal involvement as being poor prognosis. But not every one of us accept all of these criteria as they have outlined them. And the Canadians, what they also did was have a stratification. Don't be involved too much with looking at all the little permutations and ramifications of their staging system. But what they were interested in doing was comparing their patients with the same risk factors as those of the Germans. And they were able to call them out. And the big difference here is that with the German study, with the German study, you're getting chemotherapy and radiation, and with the Canadians, you're getting more chemotherapy but no radiation. So a study not too different from the previous study, and again, they have culled out the same group of patients so they could look at what was the results of just using chemotherapy versus a little bit less chemotherapy and radiation. The results showed that you did get better disease control with the group that got radiation, but the overall progression-free survival and the overall survival were pretty much the same. Again, you got better disease control with the radiation, 6% difference. But because of complications, it turns out that your progression-free survival and overall survival were the same. So in summary, combined modality therapy improves disease control by about 4 to 7%. That's what you'll get from the radiation. But superior long-term survival with combined modality therapy is highly unlikely, and selecting patients at lower risk of disease recurrence if treated with ABV alone, if your criterion are very, very rigid, you can do very well with just chemotherapy alone. And one of the things we don't know is even though the radiation that's being used is a lot less than what we used in the past, we still don't know what the complication rate will be 10 or 20 years from now. We certainly know that the complication rates in those patients who receive 4,000 rads is quite considerable. Now, what to do for relapsing and refractory disease? I'm only spend a little bit of time on this because we're going to hear plenty of this from the subsequent speakers. But here's just some brief evolving data on brentuximab vedotin. Basically, what brentuximab vedotin is, it combines a toxin, MMAE, monomethyl auristatin E, with a linker to the anti-CD30 antibody. Now, one of the nice things about CD30 is expressed not only on Hodgkin's disease, but also on anaplastic large cell lymphoma. The CD30 antibody hits the target, which is the Hodgkin cell or the anaplastic large cell lymphoma cell, and it gets internalized. The toxin is released. It really interrupts the microtubule network and interferes with spindle formation and kills the cell. So that's basically what brentuximab vedotin is. And I just want to talk about one study. There are multiple studies on the long-term survival analysis of an ongoing phase 2 study of brentuximab vedotin in patients with relapse or refractory Hodgkin's lymphoma. This is the overall survival after treatment with brentuximab vedotin. 59% of these patients remain alive with a median overall survival not having been reached with approximately 30 months of follow-up, and the estimated 24-month survival rate is 65%. As you can see here, those patients who get a complete remission, 91%, do extraordinarily well in a group of poor prognosis patients, as opposed to those who had a partial remission and those who had either stable disease or who had progressive disease. But this is very, very impressive. In this 91% of patients, as you can see here, they're not even close to reaching a median survival at beyond 3 years of treatment. And what's also interesting is how important PET scans are, because as you can see here, those people who had a PET negative scan did a great deal better than those who had a PET positive scan, showing the utility of this particular modality of diagnosis. So in conclusion, after a median observation time of over 2.5 years from the first Brentuximab vedotin dose, 60 of 102 patients remain alive at last follow-up. The median overall survival has not been reached. The estimated 24-month survival rate was 65%. And improved overall survival was strongly correlated with both the achievement of a complete remission, which we mentioned, and a negative PET scan at cycle 4. It would be interesting to see what the survival rate would have been with a negative PET scan after cycle 1. Now, what are we doing for advanced stage Hodgkin's disease? What's new? Can we improve the cure rate and reduce the toxicity for advanced stage disease? This is a frontline therapy with Brentuximab vedotin combined with ABVD or AVD in patients with newly diagnosed advanced stage Hodgkin's disease. And this was chaired by Dr. Ansel from the Mayo Clinic. Dr. Eunice has played a major role, and we'll hear from him later, in the development of Brentuximab vedotin. And basically what they did is they had an escalating dose of Brentuximab vedotin, which was given with each cycle of chemotherapy. So what they did here is they combined this antibody in patients with disseminated disease with the classic ABVD. What they found was that they got an extraordinarily high complete remission rate, about 95% and 96%. They dropped out the bleomycin because they found that the lung toxicity combined with Brentuximab vedotin was just too great. But regardless of dropping out the bleomycin or not, they got this extraordinarily high rate for disseminated Hodgkin's disease. They did have to use, though, a slightly lower dose of Brentuximab vedotin. So in conclusion, the recommended regimen was 1.2 milligrams per kg, which is a little bit lower for the Brentuximab vedotin, every 2 weeks combined with AVD. AVD combined with Brentuximab vedotin appears to be well tolerated with manageable adverse events. However, the jury is still out on this because there is potential for combined neurotoxicity. We know that the concomitant administration of Brentuximab vedotin and bleomycin is contraindicated due to pulmonary toxicity, but the complete remission rate at 96% observed at the end of frontline therapy with Brentuximab vedotin combined with ABVD is really pretty impressive. So this will await randomized controlled phase 3 trials. The last study I'd like to talk about is BEACOPP versus ABVD, and this is a study by the EORTC lymphoma group in Europe. What they were interested in was looking at ABVD versus classic BEACOPP, as generally advocated by Dr. Volker, who was the father of BEACOPP. No radiotherapy was given in this particular study, and again, this study was for disseminated disease. What they found was that the control of the disease was superior with BEACOPP over ABVD. However, there was a considerable more toxicity from BEACOPP. Anyone who's used BEACOPP does not need to be told this. It's a lot more difficult to give than ABVD. As it turns out, BEACOPP is the gold standard in Europe, and ABVD turns out to be the gold standard in the United States. But as you can see, there were far more complications from the BEACOPP than from ABVD. So as a result, the event-free survival turns out to be virtually the same. And not only is the event-free survival the same, but overall survival is also the same. There's no statistical difference. So in conclusion, event-free survival, the primary endpoint, was similar between treatment arms. However, more progressions or relapses were observed with ABVD, while early discontinuations were more frequent with BEACOPP. So you're trading off response for toxicity. In this high-risk group, which these disseminated Hodgkin's patients were, a conventional dose escalation with BEACOPP of 4+4 provides a better progression-free survival compared to ABVD, yet not enough to improve overall survival because of the complication rate. And one has to give additional considerations: treatment burden and cost, fertility issues, risk of relapse, risk of salvage, immediate and late morbidities, in guiding what you decide to give, whether this be ABVD or BEACOPP, which currently may share the claim for current standard of care. And as I said, the standard of care in the United States is ABVD, and in Europe it's BEACOPP, although I think that's going to change. So the bottom line of what I've showed you very briefly is that 3 cycles of ABVD without involved field radiation has an excellent outcome for favorable stage 1A and 2A patients using strict criteria for complete remission. That disease control may be slightly better for combined modality therapy, ABVD plus radiation, as compared with chemotherapy, about a 3 to 7% advantage, although a survival difference is unlikely because of the furthermore, the long-term effects of involved field radiation, even though it's a lot less than we used to give, is still unknown. In a retrospective analysis, survival of relapsed refractory Hodgkin's patients was superior with Brentuximab vedotin compared with treatments prior to the advent of this toxin associated with an antibody. And the role of Brentuximab vedotin in autologous stem cell transplant is now an investigation, combining the 2 of them together. And Brentuximab vedotin plus ABVD results in PET complete remissions after treatment, comparable or perhaps superior to ABVD alone for patients with stage 3 and 4 Hodgkin's lymphoma. And again, phase 3 comparisons have now been opened, and it'll be interesting to see if we get an enhanced cure rate without enhanced toxicity. But the jury on the toxicity, I think, is still out. We'll hear more about that. A general survey of studies comparing BEACOPP to ABVD almost all consistently, and there were other studies that were done as well, show a superior progression-free survival for BEACOPP, but long-term survival seems to be comparable due to the toxicity of BEACOPP. As with limited stage disease, I pose, can an interim PET scan be used to select out those patients with advanced disseminated disease not needing more aggressive therapy and thereby avoid all the unnecessary toxicity of BEACOPP? What I'm saying is, what happens if we do a PET scan after 1 cycle? If the patient is negative, keep them on ABVD. If the PET is positive, you do a second scan. If the PET is still positive, biopsy and see if you still have disease. Always biopsy, because you can get false positive PETs. If you have disease, then you can decide whether you want to go to BEACOPP or whether you want to go to an auto transplant. Dr. Deal, who is the father of BEACOPP, contends that you have genetic instability and you need to get to them very quickly. But I can't conceive of having to get together getting together earlier was going to make a whole lot of difference after 1 or 2 cycles. I just don't think genetic instability plays that great a role. So with that in mind, I'd like to acknowledge my co-investigators at Cornell, and I thank you for your attention.